hear from Professor Frank Iardino.
Right, thank you. All right, so tonight's talk that I want to try and cover in about 40 minutes is on transplant immunology and transplantation, mainly focused on renal transplantation, but it's really talking about the drugs themselves. And I want to try and cover a few areas. I'd like to cover, firstly, really try and understand the allograft response. And there's two things we need to consider when we're thinking about that and immunosuppression and the allograft, the host response to the allograft is, firstly, that there's donor and donor retrieval factors and ischemia reperfusion. And then there's the classical adaptive immunity. I want to cover the immunosuppressive drugs that we use and you really cover the site of action, remembering that, in terms of action and site of action, whatever we discuss tonight applies to the drugs generally, whether you use them for autoimmune disease or other organs. How we detect the anti-HLA antibodies in terms of the allograft response, that's probably changed over the last 5 or 10 years. And look at the immunopathology of rejection. That's at the moment, our clinical gold standard for diagnosing rejection and how that defines treatment, and then some clinical outcomes from all that. So hopefully by the end of it, you'll be able to sort of understand how alloactivation and immunopathology and the pharmacology allows us to understand immunosuppression, predict immunological and clinical outcome of transplants, how to personalise our therapies, which is really where really medicine is moving towards, personalised therapy, and how we can look at preventative care in some of these patients and look at their outcomes and how we might prevent the adverse outcomes. So we'll start by going through the allograft response, and I think the first thing, as I mentioned, ischemia reperfusion is quite important, and that is the donor retrieval of the organ itself and the storage of the organ leads to cold ischemia time and warm ischemia time. I'm not going to go into how those each contribute, but that certainly leads to ischemic injury of the organ. And then when you reperfuse the organ, that certainly the ischemia sets up and primes the organ, causes the injury. The reperfusion then causes the inflammation, the so-called ischemia reperfusion injury. That then activates the innate immune system and triggers off inflammation, which involves macrophages, neutrophils, and NK cells, and also leads to dendritic cell, presenting cell maturation. I'll show you how that happens. And that then leads to the dendritic cell maturation is the key part of the classical allograft response, which is the adaptive immunity, which is the presenting cell T cells and B cells, and that's what we generally talk about, but in fact, really it gets triggered off and sets in place and amplified by the ischemia reperfusion injury. What's important in ischemia reperfusion are the toll-like receptors, and particularly 2 and 4. And these toll-like receptors, as we probably heard in other lectures, are recognition receptors of pathogen-associated molecular patterns, or PAMPs, which lead to protective immune responses to infective organisms, but also through injury and release of endogenous factors, so-called DAMPs, leads to the release of things like HMGB1, which then mediates inflammation and that ischemia reperfusion and that so-called sterile inflammation. And that's quite an important response, which has really been understood in the last, in the last little while. Now, the innate immune system and ischemia reperfusion leads to upregulation of these toll-like receptors, the HMGB1. There are a whole lot of other things that get released, heat shock protein and others. These important molecules then mediate inflammation through things like NF-kappa B by binding to the toll-like receptors and other receptors such as the RAGE, or the advanced glycosylation end product receptor, also called RAGE. That then sets in place activation of macrophages, neutrophil, dendritic cell activation and maturation, leading to alloactivation and the adaptive immune response. What's important here is that the toll-like receptors act through pathways. The so-called MYD88 is the signalling molecule for these receptors and other receptors, and these trigger off inflammation. There are agents now being developed that target those pathways, and so you will see over time therapies targeted at the donor and the donor organ ischemia reperfusion injury as time goes on. And these have been conclusively shown to be involved through various laboratory experiments where they've actually knocked these receptors and pathways out. Also to say that that the release of ATP, which is in fact through necrotic cells and so forth, is pro-inflammatory, and so other pathways through these P2 receptors. And there are protective pathways through CD39 and 73 which convert ATP to adenosine, and adenosine being act on adenosine receptors which down-regulate inflammation. So these are protective and these are pro-inflammatory. And they act through macrophages, lymphocytes, and even possibly regulatory cells, neutrophils and NK cells. So these are the pathways that are important in ischemia reperfusion injury. Now, once the organs then is in the host, then you get the classical adaptive immune response, where you get a presenting cell with a host T cell, which then gets activated through recognition of either a self-APC with donor peptide or with a donor APC that stimulates a host T cell. And that, as we know, involves three signals. Signal 1 through the T cell receptor, signal 2, which is co-stimulation, and that's important. These are all therapies, these are all pathways where therapies are actually targeted, and I'll show you where our immunosuppressive drugs work. And then there's signal 3, which then 1 and 2 leads to activation, transcription of cytokines, and then signal 3 through the cytokine receptors leading to T cell proliferation. These are the intracellular pathways involved, calcineurin being one of the key factors. These pathways are all pathways where therapy is being targeted towards, as is the co-stimulation pathway. The best known one is belatacept, which is the CTLA-4 co-stimulatory pathway being targeted, and then the cell cycle replication, and there are, we know, drugs targeted at that, such as mycophenolate and others. And that leads to T-cell activation and cellular activation, and then these migrate into the organ causing cell-mediated rejection, which we will diagnose through our pathological or immunopathology and our pathology when we do the biopsies. This is just looking at that pathway in a bit more detail, just to say that the signal 1 and 2, these cytokines that are released, it's not only IL-2, there are others like IL-15. They act on the receptors, and they then target through kinases and other signaling molecules like mTOR and these JAK kinases, remembering, and I'll show you where these are actually targets of our therapy to indicate where these this pathway being a key pathway to then lead to DNA replication and T-cell proliferation and amplification of the T cell response. And these are all pathways that are targeted by our therapies. It's also important to know that T cells and B cells talk to each other, and that B cells then get activated to produce antibodies. Again, very similar. B cells are presenting cells through the class 2 on B cells, talk to T cells. They activate and talk to each other. T cell help causing B cells to maturate, predominantly through CD40 and maturation of the B cell to produce anti-HLA antibodies, remembering that the target of the rejection response is donor HLA. And that B cells also lead to, as presenting cells, continually activating T cells. So this is a two-way interaction leading to predominantly the production of these antibodies, which are targeted to donor MHC, which then migrate into the organ, leading to antibody-mediated rejection. So rejection being a cell-mediated response and cell-mediated rejection, and an antibody-mediated response, antibody-mediated rejection, the target always being predominantly donor MHC and their donor target cells. And where do our therapies work? Well, if we look at this simplified diagram, we see that calcineurin inhibitors, cyclosporin and tacrolimus, act as signal 1, calcineurin being an important phosphatase that is important in this signal 1. CTLA-4 belatacept acts through co-stimulation, and I'll show you how that's used clinically. The signal 3, anti-CD25, our anti-CD25 antibody that we use clinically, again acts at the IL-2 receptor site. mTOR inhibitors such as sirolimus, everolimus acts through blocking the mTOR signaling from the receptor down to the DNA level. Mycophenolate azathioprine acts at the level of the DNA and DNA replication. And we've got anti-T cell therapy or depletion antibodies that basically just deplete that T cell. That's where they work. So that's if you're targeting, cell-mediated rejection. If you're targeting antibody-mediated rejection, then what we do is try to remove these antibodies through plasma exchange, modulate through IVIG, and other therapies which have not been proven but have snuck into the transplant literature, anti-CD20 and the proteasome inhibitors. But these are obviously not used routinely and still to be proven as effective as targeting antibody-mediated rejection. But certainly plasma exchange, IVIG is certainly used, and there are some units that are using anti-CD20. Now, the other thing is that I wanted to point out is how we detect these anti-HLA antibodies, and that has changed quite a bit. There are three ways. The oldest way is through cytotoxicity, and we still use that clinically, by the way, when we do a cross-match on the evening when a donor organ comes up. The cross-match needs to be, the T-cell cross-match needs to be negative for that organ to be offered, where it detects anti-HLA antibodies. More sensitive methods are through flow cytometry, and in the last 5 or maybe more, 10 years, these solid phase assays, which are beads coated with HLA that pick up anti-HLA antibodies in our donor, and the readout is the so-called mean fluorescence intensity or channel shift in our assays. And the sensitivity is Luminex, certainly more than flow, certainly more than cytotoxicity, and there are these Luminex detected antibodies through MFI is being used clinically and is being used to determine whether we allocate and how we allocate organs to our renal transplant recipients. And there is a cutoff above which we say no, that organ to that individual. if the patient's got anti-HLA antibodies detected by Luminex above a certain threshold. And so it is something that is used clinically. Just to say that there still is a lot to be learned about these antibodies, and we know using these assays like Luminex, and what do I mean by that? There's a lot to be learnt. We do use them because we know above a certain threshold, for example an MFI of 4,000, which is where we use our cutoff, that the outcome is not good. But below 4,000, we know that we have got these patients that, and there's through retrospective studies showing in the presence of donor-specific antibodies detected by Luminex, which is the most sensitive, about 40% will end up with acute antibody-mediated rejection. About a third end up with subclinical rejection. But there are a number of patients with these very low-level antibodies for which there is no antibody-mediated rejection. And so we are learning to use this assay and what these low-level antibodies mean and how we can more clearly define which are the ones that are going to go on to a worse outcome and which ones may not go on to a worse outcome, and what do these mean. And the reasons for that, why do we see these patients with low-level antibodies with no evidence? And, because these are fairly sensitive assays, as I said, assays with MFIs under 4,000. Why do we see them? Well, there are probably a number of reasons. People have looked at the isotypes, and we know that there are complement-fixing antibodies, anti-HLA antibodies, and which are the IgG 1 and 3, and then 2 and 4, there's sort of non-complement or poorly complement-fixing antibodies. And people have shown that, that these subclasses and whether they fix complement or not may relate to why some are pathogenic and some are not. It's not as clean as what I'm trying to make out at the moment, just to give you an idea that we are trying to learn how to use these antibodies at a very low level. And for example, the IgG3, which is the complement-fixing antibody, we do see that there is a tendency, if you get induced antibodies, early rejection, microcirculatory injury, as opposed to IgG4, which is a non-complement-fixing antibody or poorly complement-fixing, which tends to cause late rejection and associated with other more sort of subacute causes. So just to mention that, that there is all this still that's going through the literature at the moment, and there's still a bit to be learned. But we do use them clinically, as I said, above and below these absolute thresholds determined by MFI, and it is used in terms of how we allocate organs. The next thing I'd like to move on to in terms of defining a rejection is to give you an idea of our current gold standard, which is histologies. So the Banff classification is an international standard classification of renal transplant pathology, which defines rejection. It is used in other organs. I'll only talk about the renal organs at this, the renal transplants at this stage, and to say that this does define pathology, and it does define it in terms of cell-mediated rejection, as I mentioned before, and what therapy we use for that. And it also defines antibody-mediated rejection, and as I showed you, our therapies that are targeted towards that. So I'm trying to give you the idea that pathology, immunopathology, mechanisms, understanding that, and with our gold standard Banff classification, it does direct our therapy of rejection and what immunosuppressive drugs we use under what circumstances. To say that the Banff classification has undergone a number of changes over the years and has been modified. The only point about this is the current Banff classification, to show you that it defines a number of different categories, sort of 1 to 5 or 1 to 6, normal-looking tissue, antibody-mediated rejection, and how that's defined. Not that you need to know the details of it, but there are hallmarks of that, and the hallmarks of antibody-mediated rejection is peritubular, peritubular capillaritis. Then there is both acute and chronic antibody-mediated rejection. Then there's borderline rejection, and then there's acute T-cell mediated rejection. Again, emphasising the point that our therapies target these organs. And the hallmark of cell-mediated or T-cell mediated rejection is tubulitis, as opposed to peritubular capillaritis, which is one of the hallmarks of antibody-mediated rejection. And then there's chronic T-cell mediated rejection as defined by the pathology, and then there's chronic changes. And the other point I want to make is the more recent Banff classification changes, that antibody-mediated rejection now requires 3 levels of criteria: histological criteria, evidence that antibody interaction with endothelium is occurring, with or without C4d, and serological evidence of donor-specific antibodies, meaning these antibodies that we've just defined by Luminex, which defines antibody-mediated rejection and determines our therapies. Some examples here. This is just a T-cell mediated rejection response. The cells that I showed you that get activated with tubules overrun with T-cells. And the hallmark is tubulitis. In other words, cells invading the basement membrane and into tubules and overrunning tubules. That's the hallmark of cell-mediated rejection in renal pathology. More examples showing the tubules and cells invading the tubules, or tubulitis. The cell-mediated rejection can even involve vessels. You can see endothelium and vessel wall being invaded. This has got a worse prognosis when vessels are involved with cell-mediated rejection. Again, these stained cells are all T cells. You see this terrible look in endothelium and invasion of the endothelium and vasculature. And this is showing glomerulitis and peritubular capillaritis, which is a hallmark of antibody-mediated rejection that you require to make that diagnosis, which puts in place a whole different type of therapy and targeted therapy, which you need to target the antibody and the B cells as opposed to T cells. Okay, so now just a bit about pharmacology to try, and I'll go through this fairly quickly because a lot of this is known and you'll have the lecture notes, but you know, calcineurin inhibitors, cyclosporin and tacrolimus, it's well known how these work. These bind to cyclophilin, and we know that signal 1, that calcineurin is a phosphatase molecule that binds to calmodulin and calcium to dephosphorylate this so-called transcriptional factor NFAT, or nuclear factor of activated T cells. That then, once it's dephosphorylated, moves to the nucleus as a transcriptional activator of cytokines. Cyclosporin gets into the cell, binds cyclophilin, and inhibits this complex. So, and that's how it works. And this molecule that it binds to become activated is a so-called cyclophilin. Now, tacrolimus does exactly the same thing, but the binding protein is this FK binding protein 12, which then binds to form and inhibit calcineurin, and is a potent inhibitor of signal 1 and a potent inhibitor of cytokine secretion. Mycophenolate, on the other hand, works late. Mycophenolate is a reversible inhibitor of inosine monophosphate dehydrogenase. It's used in transplantation. It's used in a whole host of immunological diseases. And it's a potent inhibitor of this inosine monophosphate dehydrogenase, which is important in de novo the guanosine nucleotide synthesis pathway. So it's a direct inhibitor of cell replication at the DNA level. Now, a few things about mycophenolate that you're probably important to know about. Firstly, mycophenolate is absorbed and is taken up and is converted to mycophenolic acid, or MPA. This is the active form of mycophenolate. Gets into the circulation, and it's this that acts on lymphocytes to inhibit. But importantly, mycophenolic acid enters the enterohepatic circulation and gets a glucuronide molecule sucked to it, or MPAG, which is inactive. However, the MPAG is renally excreted. That's fine, but MPAG also enters through the enterohepatic circulation, gets back into the gut, and through gut flora gets converted back to mycophenolic acid, and then enters the enterohepatic circulation. And so what you can see there, that if you do get accumulation of MPAG, as in renal impairment, you can get excess amounts of mycophenolic acid being produced. That's the first thing. And when you look at that enterohepatic circulation, it's what produces this second peak when you get the initial absorption of MPA production, followed by this secondary peak, which is the enterohepatic circulation. Now, it's important for two reasons. One is when you're using it with cyclosporin, that produces a reduction in MPA or mycophenolic acid exposure through inhibiting that enterohepatic circulation. And number two, that enterohepatic circulation with the MPAG production, which is renally excreted, with renal failure, you get accumulation of the MPAG, which then goes back through the enterohepatic circulation and produces more MPA back through the gut flora with the conversion. And so when your GFR falls below 30, consideration needs to be given to dose reduction, although we don't always do that. But it is important to realise that your patient with renal failure and mycophenolic acid and mycophenolate is going to be increasingly immunosuppressed through higher levels of MPA. Monitoring. Do we monitor? Look, I don't want to go into this in detail other than to say that the jury is still out. There are a number of studies that looked at whether therapeutic drug monitoring with cyclosporin and tacrolimus, yes, we do monitor. With mycophenolic acid or mycophenolate, the jury is still out. 3 studies, and one of them has shown that with fixed dosing as opposed to concentration-controlled or therapeutic drug monitoring, that you can, if you target, reduce your rejection rates. 2 other studies, although I won't go into the details, flawed in some areas, have not shown a benefit. However, I think at the moment the jury is still out. We do need more prospective studies. We generally, not all units, although we do, monitor, do therapeutic drug monitoring for mycophenolate, as there is studies to suggest that there is a relationship between low exposure to mycophenolic acid and rejection rates. So I think that as I said, the jury is still out, but I suspect as time goes on, we're going to be able to show that, in fact, probably in certain scenarios that we probably should be monitoring therapeutically the MPA, although that's a personal opinion as opposed to standard therapy. Now, the mTOR inhibitors, sirolimus being one. Now, that's an interesting one because that's now coming very much into fashion. Sirolimus is one, the other one is everolimus, gets into the cell, and interestingly, the binding protein for sirolimus is this FK binding protein 12, which is exactly what tacrolimus binds to. Remember, in tacrolimus and sirolimus are macrolides like erythromycin, and they bind to this FK binding protein 12, which is what FK binds to. However, it doesn't inhibit calcineurin. It actually inhibits this target of rapamycin signalling molecule. So that's one important point, and it does go through, it is metabolized to the cytochrome P450, and so there is all those drug interactions associated with that. The mTOR inhibitors, I'll show you how we use these clinically in a moment, but they are anti-proliferatives. They do arrest through inhibiting cell proliferation, both immune and non-immune cells, so T cells, B cells, and so they are immunosuppressive, but they also block non-T cells, fibroblasts, and so they do impair wound healing. So you've got to be very careful when you're using this drug and you've got someone who's having major elective surgery, whether you decide to change them from that. And as the other good example where it's used for its non-immunological effects is, these drug-eluting stents. That's the drug that's used in the drug-eluting stents to inhibit or reduce the rate of stenosis. Its anti-proliferative properties has also been proven to be of benefit in malignancies, and it's got an anti-cancer property through probably also anti-angiogenesis effect through reduced VEGF levels, and the oncologists also use it. So it's got an attractive use in transplantation, as you know, and I'll show you that malignancy is a major problem for our long-term patients. And it's also got anti-proliferative and antiviral properties in vitro, and in fact in the studies it does indeed in some studies translate to lower rates, I should say, of CMV infections. Just to say, its use, for example, it's got certain specific use, for example, in tuberous sclerosis, and you know that in tuberous sclerosis, the tumour repressor genes are defective. That then leads to overactivity of mTOR, which leads to tumour growth. And so it's got a specific use in tuberous sclerosis, in angiomyolipomas and other tuberous sclerosis-related tumours through this mTOR pathway, which is specifically overactive in patients with tuberous sclerosis due to these repressor genes being defective. And just to show that it is used by the oncologists in a whole host of cancers, which I'm not going to go into, but the notes are there for you to have a look at. So some of the clinical issues, just there for this last part. What are some of the clinical issues with that immunosuppressive drugs, how we use them, and how we can personalise some of this therapy, and how we can prevent rejection? Now, the first thing to say that what are some of the clinical problems? Well, firstly, long-term allograft loss still is a major clinical problem. What are the causes of long-term allograft loss? Well, firstly, we know that it is multifactorial, but it is due to immunological causes. So in other words, long-term slow allograft response and our alloactivation, which the pathways I've showed you earlier. and part of it due to probably the calcineurin inhibitors, which we know are nephrotoxic. We thought that some years ago that it was CNI toxicity was a major factor. Probably still is a factor, but we now know that immunological causes of chronic allograft loss is probably more important. The other cause for long-term allograft loss is death with a functioning graft. In other words, patients dying with a functioning graft. What do they die from? Cardiovascular disease and malignancy. And so you can see where it may be attractive to start using things like mTOR inhibitors in our immunosuppressive protocols. Recurrent disease, diseases such as focal sclerosis, IgA, and BK and BK nephropathy. Just to show, this is ANZ data. This is our registry that we've got in Australia, New Zealand dialysis transplant registry. This showing graft loss, showing the reasons for that, and you can see that death with a functioning graft is a major cause, as is chronic allograft nephropathy, and I've showed you the reasons for that. So this is now borne out in our registry data. To show you that graft loss, if you break that down, the cause of graft loss and death with a functioning graft, cardiovascular being important, cancer being important, and infections in our immunosuppressed patients. And chronic allograft loss, which I indicated was largely due to immunological reasons, and also probably from calcineurin inhibitor toxicity or nephrotoxicity. This just goes to show you patient survival for the Australian New Zealand population. This is the Australian population showing that years and patient survival. You can see that over the years that we have gotten better in managing our patients with better survival rates. At 10 years, we're getting, 80% or more patient survival, which is significantly better than remaining on dialysis. Allograft and allograft loss, and I just showed you the reasons for this allograft loss and for the patient loss on the previous one, that we have got better and better and better with our immunosuppression, with better short-term survival at least, but you can see that we still are losing these grafts steadily over that time. So still not perfect, and the reasons for that is that, as I've outlined already. And that antibody-mediated rejection is a reason for the chronic allograft loss. I might just move along to try and finish up in the next few minutes. This showing what have we done over the years, again, that we've got better at managing cardiovascular disease and aggressive cardiovascular targeted therapy, in other words, statins, blood pressure control, treating diabetes. We haven't got that much better at treating malignancies, although we hopefully will get better outcomes with our smarter use of immunosuppressive drugs and things like mTOR inhibitors. We've got better at managing infections over the years, and these are other causes. You can see that as the years have gone on, this is patient death. In the blue is malignancy, that is a time dependent and is a bigger cause as time goes on. And this green is a steady cardiovascular causes of death, which has remained steady as time goes on. But the big growth pattern is in malignancy as time goes on. And this just showing you that after 30 years of immunosuppression, 80% of patients with transplants, renal transplants, will have some form of cancer. This is the general population. And most of that, a lot of that cancer is skin cancer. And we know that mTOR inhibitors can reduce that risk, and so we are probably going to start to see an impact of that, hopefully, as time goes on. Cancers in transplantation, virally driven cancers, viruses driven by immunosuppression, and I'm not going to go into these viruses and what they cause. but lymphoma, Kaposi's being big ones. Now, studies showing, that mTOR inhibitors, this is the CONVERT study where we converted patients to mTOR inhibitors, showing that conversion to mTOR inhibitors does translate to lower cancer rates, and this one's showing lower skin cancer rates with conversion to sirolimus. And now this study, which I want to highlight, which has really been a landmark study, the Symphony study, which has driven our current protocol in transplantation, renal transplantation these days, which looked at low-dose tacrolimus, low-dose cyclosporin and low-dose sirolimus together with mycophenolate and an IL-2 receptor blocker. The Symphony study has, as I said, shaped our current day immunosuppression, and what it did show was that there was certainly a better GFR with mycophenolic acid, tacrolimus, prednisolone and IL-2 receptor. I won't go into this study in detail, but just to say that it produced a better GFR. You can see here that with the mTOR inhibitor, higher rates of delayed wound healing, as I mentioned, was a bit of a problem. Higher rates of lymphocytes with the sirolimus, and lower rates of CMV, as I mentioned, antiviral properties. But overall, the renal function and the outcomes were much better with a combination of tacrolimus, mycophenolate, prednisolone and IL-2 receptor blocker. And that is what we'd consider as our standard therapy these days for most patients with immunosuppression. I'll show you some evidence for that. To say that the other growing use and a study which is, the results are just about to come out, so I can't give you those results, is the TRANSFORM studies. Can we get the benefits of mTOR inhibitors by combining mTOR inhibitors, CNI inhibitors with prednisolone? This is, in other words, to get the benefit of anti-cancer property and antiviral properties and compare that to standard therapy. This study, which is called the TRANSFORM study, is probably one of the biggest phase 4 study, which is over 2,000 patients, and is comparing everolimus with CNI, which is tacrolimus or cyclosporin, compare that to our active comparator, which is mycophenolic acid, prednisolone, and the CNI, which is essentially the Symphony protocol in summary, really. Not quite, but... And it's to see if we can get better outcomes and lower cancer rates and lower viral infections. The results of these will probably come out in the next few months, so I'd be looking out for that in terms of the literature and whether that changes our current practice. The last study I wanted to mention is this, the use of belatacept, which has crept into the transplant literature, the so-called BENEFIT study and BENEFIT Extend, which is belatacept blocking co-stimulation, which is being used as a CNI free to free up patients from CNI use. So it's essentially belatacept with mycophenolate use, and it's the high intense arm and the low intense arm. The early studies showing some concern with higher rates of PTLD, so there was a concern initially, although they did end up with better GFRs when we used belatacept with mycophenolic acid in the absence of CNI. However, in a paper from the New England, a 7-year follow-up in the New England paper from last year showed after 7 years that there was that the concern about PTLD was not borne out in the later follow-up studies, and importantly, there was better patient outcome and better graft outcome in that 7-year follow-up study. So that's something that may creep more and more into use with this positive 7-year outcome study from the New England paper from last year. And just the last 2 minutes to show you, this is what current practice is. This is the Australian New Zealand Transplant Registry showing what we use as standard therapy. Initial treatment at 1 year and 2 years. And you can see that based on the studies I've just mentioned, that the commonest is tacrolimus, mycophenolic acid, or mycophenolate, and prednisolone. At 1 year, continues to be that rather than cyclosporin, and also in the long term it still remains tacrolimus, mycophenolic acid, and prednisolone. And you can see that prednisolone and prednisolone withdrawal is something that is not practiced as much now as it used to be, relating to some outcome studies, which I won't go into. And finally, these are showing what is it showing? That antibody use and antibody induction, that pretty much standard now is the IL-2 receptor blocker that's used in most transplant immunosuppressive protocols. So the combination of IL-2 receptor blocker, prednisolone, mycophenolic acid, and tacrolimus, essentially the Symphony protocol. Rejection rates around 13% in living donors and about 16% in deceased donors. And then finally, antibody-mediated rejection rates of about much lower, 2% and 3%, more difficult to treat. And I might just end it there. So I hopefully covered, what we would consider our understanding is of the allograft response, where the drugs work, how we use them, and how we manipulate them, and where the therapy is moving towards in terms of trying to get better outcomes with reducing cancer rate, cardiovascular risk, death with a functioning graft, and trying to reduce those rejection rates to get better outcomes for our patients. That's it. Thank you.
And
questions?
We'll invite any questions at this stage. Please thank our speaker, Dr. Frank Iarino. And thanks for joining us, everyone. Have a